In ICSI, I'm going to explain the short or the antagonist protocol. Typically, when a patient comes for ICSI, either of the protocols, that is ovulation induction protocols, are used. You can either use the long protocol or even the short protocol. Since I've already explained the previous protocol in detail in my IVF video, in this ICSI video, I'm going to discuss the short antagonist protocol so that the instructions to the patients are clear. Short antagonist protocol usually starts on the day 2 or 3 of the periods. So instructions are given to the patient to stop the oral contraceptive pill on a particular day. Of course, the hysteroscopy is performed while the patient is on oral contraceptive pill, that is in the previous cycle. Once she stops the pill, typically in 4 to 5 days, she will get her periods. Once the period comes, she is supposed to inform the unit, and on day 2 or day 3 goes for a sonography. If the sonography shows a thin endometrium, no ovarian cysts, she is started on gonadotropin injections. The injections start on day 2 or day 3 of the cycle. These go on for 8 to 10 days till the follicles are ready for pickup. So after day 2, the patient again reports back to the clinic on day 6. Of course, in the meanwhile, she's taking injections daily. Now, this is only one set of injections which is started on day 2. So on day 6, when she reports for a sonography, if her leading follicle is 12, 13 or 14 mm, then the second set of injection is started. If it is 13 mm, because we usually call the patients after 2 days, I would start the antagonist injection the next day. If the follicle is already 14 mm, the antagonist injection would be given on that day. The important thing to remember about this antagonist is that it has to be taken every day till we give the HCG or the trigger, and usually try and stick to the 24-hour interval. The other gonadotropin injections can vary. If you take them even at 2 o'clock or 4 o'clock or even 8 o'clock, it does not matter. But the antagonist injection should be typically kept at a 24-hour interval or lesser. So once the sonography is done on day 2, day 6, day 8, by day 9 or 10, the patient is usually ready for an ovum pickup. So that means the follicles have reached anything between 17 to 20 mm. Once they have reached this size, the trigger is given of HCG, and then the patient is typically admitted. If the trigger is given on Monday, she's admitted on Wednesday morning. You have to come nil by mouth. That means no water or no fluid or no solid intake for the last 8 hours at least prior to getting admitted. Usually the patient gets admitted in the morning, then she's taken into the operation theatre and ovum pickup procedure is done. This is done under general anesthesia. It's a short GA, takes about 10 to 15 minutes, performed with the help of a needle and under the guidance of ultrasound or sonography, and after which the patient goes back to the ward and she is discharged after 3 to 4 hours. In the meanwhile, the sample is collected from the husband. Occasionally we've had a problem where the husband is unable to collect the sample. Then the frozen backup, which is kept in the semen bank, is utilized. So this sample is taken. Now in ICSI, the process in the laboratory is different. What we do is we take these eggs, they are incubated for 2 hours and then they are dissected. Once they are dissected, we identify the mature eggs. That means the M2 eggs. Then these mature eggs are taken and actually with the help of a machine called the micromanipulator, 1 egg and 1 sperm is picked up. So this sperm is picked up and injected into the egg. So what is achieved naturally in IVF is achieved with the help of the machine called the micromanipulator in ICSI. Now this is typically used for patients of male infertility where the semen count is low, the motility is poor, the morphology is bad. Another advantage or another advancement in the field of ICSI is IMSI. That's in this particular condition, in this particular technology, what we do is we enlarge the sperm 7,200 times. So we are able to pick out the best sperms, and that sperm is actually taken and injected into the egg, and we've seen a difference in pregnancy rate. It has definitely improved our pregnancy rates in these patients. After the egg is injected, the egg is kept in the incubator for 48 to 72 hours. And once the fertilization occurs, these embryos are then checked Once the patient is ready for embryo transfer, we typically transfer 2 or 3 embryos back into the womb. Extra embryos that are formed are actually, the patient is offered embryo freezing, and these embryos are vitrified and kept for use. I've had a lot of patients who've conceived the first time and they've used these frozen embryos for a second baby. But sometimes, unfortunately, we can't get everybody pregnant. So those who fail in the first attempt do not have to undergo the whole ovulation induction. They just take pills to prepare the lining of the uterus and undergo a frozen thaw embryo transfer. So these embryos, which are kept in the embryo bank, are then thawed and put into the womb. So typically, out of one cycle, a patient gets 2 or 3 attempts, and her cumulative pregnancy rates definitely go up with this process of embryo freezing.